Now I'd like to introduce you to our presenter, Gail Arno, the Director of Care Management for Elder Care Management. Gail began her career in aging services in 1998, serving as a family consultant for a local placement agency. She actively educated and guided a generation of seniors and their families to resources and information available throughout the greater Sacramento region. In 2010, she brought her experience and expertise to the team at Elder Care Management, providing service and oversight in the growing field of geriatric care management. In 2020, Gail assumed the role of Director of Care Management for ECM, leading the exceptional team of established care managers. Gail received a Bachelor of Science in History from UCLA and a Bachelor of Science in Psychology from CSU Northridge. She also completed a graduate certification program in gerontology through CSU Sacramento, where she concurrently completed a 6-class case management course certification. She is a California Residential Care Facilities for the Elderly, or RCFE, certified administrator, and is a state-approved instructor for RCFE administrators certification courses. She is a volunteer for the Alzheimer's Association and a board member for Del Oro Caregiver Resource Center. Gail is a certified care manager through the National Academy of Certified Care Managers and a member of the Aging Life Care Association. Gail offers invaluable wisdom on the subject of aging, and with that, we will let her take away the presentation. Gail?
Thank you so much, Maureen. I appreciate that. Very kind and very good direction as we march through these slides. And then thank you so much for that honorable introduction. And thank you everybody for joining us as we go about talking about this topic of the challenge of the emergency room and then subsequently the possibility of a hospital admit, particularly at this time and this stage of the game that we're all facing. So we're going to address this topic and also talk a little bit about COVID and how you go about navigating this environment with that dilemma in front of you. So thank you again, everybody, for joining us. And let's dive right in and talk a little bit about some of these issues. First and foremost, when is it time to go to the emergency room? I think everybody right now is I don't want to go to the emergency room. I don't want to get COVID. I don't know. I think at this time, everybody's on such heightened alert, particularly at the emergency room and in the hospital, that they are doing their darndest to kind of keep us isolated and away from one another. That being said, you may not avoid a diagnosis of COVID upon an ER visit or a hospital visit, but certainly not the intended outcome. You know, I think you have to sit back and question, is it dire enough to go to the emergency room? And I think the best guidance I can give you is, when in doubt, make the call. Absolutely. You know, so many of our seniors and so many of our loved ones say, you know, I'm fine, I'm not hurt. And then moving is so uncomfortable and so cataclysmic. So we are not diagnosticians. We are not X-ray or CAT scan machines. So things on the outside might look good, but things on the inside are not so good. So when in doubt, err on the side of caution and get to that emergency room. We're going to talk about what you should bring. What can you bring? And how do you best prepare for an incident like this? And we actually have some really good tools and techniques, how to keep track of all this information, etc. So we're going to talk quite a bit about that litany of items to bring and what to be prepared for. Again, we'll discuss the COVID-19 impact and the concerns. You know, how do you work around that? What do you do with the COVID-19? And I'll tell you honestly, yeah, and you're going to see this, it's going to shift day to day. I recently had a reason to take a loved one to Stanford, and the day before they called and said, don't bring this, and then the day of, do bring this. Even the highest institutes are just very confused, and everybody on staff kept saying, we're so sorry for the confusion. They change the rules every day as we go along. And we've experienced that just this week when Governor Newsom, I was going to say Governor Brown, wow, that dates me. Governor Newsom definitely, you know, it's changed the guidelines and our level, our tier as it might be. And so there's ways to work around a little bit around that and how to get your thoughts across and maybe your presence available to support your loved ones. I'm going to talk about what to expect upon arrival. I think the biggest thing that you've got to prep yourself for is hurry up and wait. So again, we'll talk about how do you offset that hurry up and wait tone. What are your treatments? What are the diagnoses? What are the changes, etc. So we'll go into some detail regarding that. And then what if it is ultimately an admission to the hospital? What are you looking at? What are the questions? What are the concerns? What are the outcomes as a result of an admission to the hospital? And then upon discharge, what are you looking for? What answers do you have? What additional tools did they give you? And where will you go from there? So we want to make sure that all of that is available to you, etc. So we'll talk about how to go forth and gather all that information and know how to manage that. So again, when to go to the emergency room, call 911 if it is life-threatening. But again, I don't know what is life-threatening to one versus the other. I can tell you some of the markers to look for heart attack or stroke. We've been told, particularly in a stroke, that we would be looking for symmetry in a smile. We would be looking for the ability to raise arms in a symmetric fashion above our head, be able to repeat a sentence back, but again, I am not a system to diagnose out in the field. Those tools and techniques are inside the institution that has the proper diagnostic abilities. Same thing with a heart attack, chest pain, etc. We know that to be possibly, an element of a heart attack, but do we just stick with that and assume it's a heart attack? We need to get into the ER in that case. Any symptoms we have of concern, and we all have been so inundated with the concerns and the worries of symptoms of COVID, do we go in, can we manage those symptoms, etc. But if there are symptoms of concern, it is just best and wise to get those symptoms addressed by the professionals. I know that ER visits can be a very long, exhausting experience. Surprisingly, I think their goal is to get you in and out sooner and faster than ever, if that's the case. So there may be that opportunity to get in and out as quickly as possible, as it might be. Additionally, a fall, and this is where I just implore you to hugely err on the side of caution. We don't really have a lot of tools to prevent falls. I think we have more tools to react to falls, unfortunately. Falls are a part of the aging process. Some of us go down more gracefully than others, but a fall, particularly an unobserved fall, is an issue that really needs medical attention. Once again, I'm not an X-ray system. I can't look at your hip and determine it's fractured. I can't look at a pelvis and determine that there is a hairline fracture, a compression fracture of the vertebrae, etc. We hit a head, and heads maybe we don't have, skin that's broken open, but we may have a contusion underneath that hit. And that contusion may be a concern and may lend itself to a hematoma where there's a bleed in the brain. So again, falls are a major concern particularly for our aged cohort that we're keeping our eyes on. We really should not help people up from a fall. We can give them instruction on how they can get themselves up from a fall if they can cognitively follow those instructions, but assisting someone up from a fall may actually further injure them. So again, this is where we would prefer to get a professional viewpoint of that fall and of what the outcome from that fall might be. And then that abrupt onset of additional confusion or a change in cognitive or mental status. I think it's, for those of us in the industry, not surprising, but those of us newer to this aging process, believe it or not, a urinary tract infection can bring on a very abrupt onset of confusion or change in status. And one might say to themselves, well, what does the urinary system have to do with that cognitive ability? And there's actually so much it has to do with that. Dehydration can bring on confusion. So again, all of these issues can be readily addressed in a medical environment and really merit and probably warrant hopefully a quick in and out visit in the emergency room. So I think again, erring on the side of caution is really our best answer to these concerns about when is it time to go to the emergency room. So what do I bring when I go to the emergency room? Well, we're going to tell you, you should bring someone. It's so important to have an advocate, and that's a big role that we play with our clients and those that we do care management and or personal care for. Someone who can advocate and articulate when you, the patient, cannot or may not be able to. So a historian, someone with some good knowledge, some good background, and we're going to give you the tools and the items that in particular that you're going to need to bring when you walk into an emergency room. We have a toolkit packet, and Maureen will be very happy to send you a copy of our toolkit packet. It's a number of pages that just asks for all the volume of information that you're going to be asked for of when you hit the emergency room. And if your loved one can't articulate those answers, now the emergency personnel, they're working a little bit blind, and they need to have that opportunity to really know what your medications are, who your medical delivery system is, what your allergies might be. All of those bits of information are really, really advantageous for the emergency room personnel to make a better assessment of what might be going on. One of the important things that you really need to bring a copy of would be either the POLST or the Advanced Healthcare Directive. And I'm going to pop to the next screen so you can see a copy of the POLST. This is what the POLST looks like. It's referred to as the physician orders for life-sustaining treatment. And this is really the document of choice these days. It is a medical document, as you can see by nature of the name, physician's order. It is typically signed by the physician or the nurse practitioner in the office. And as you can see in this example, it gives you all the opportunities to communicate, particularly if you can't, and particularly if you're the recipient of care and you're not able to articulate and you can't have someone with you, this POLST would speak for you in that absence. So this is a really important document. This should be at home on the refrigerator. It should be in everyone who supports you, particularly your powers of attorney for medical. It should be in front of them. We keep a copy of every single one of our clients' POLST on our phone in a HIPAA protected application. So we can land at the emergency room and present a copy of that right away so that the emergency personnel can respond. As you can see with this POLST, you have options here. We're either fully resuscitating completely or we're not resuscitating. And then under the category B, if we are doing full treatment, it speaks to trial periods if possible, if we're doing selective treatment, if we're doing comfort treatment only, etc. So you can see this document is really a valuable document and has really addressed the issues. And I just really can't say enough about the value of having this document with you. Now, if you've completed this with your physician, then your physician and the delivery system that you're attended to, such as, if you're with Mercy, that's one thing. If you're with Kaiser, another. Here's the rub. You may think, oh, well, the medical system has it. I don't need to worry about that. What if it is a heart attack and you are away from your medical delivery system and you're taken to a hospital that isn't the norm that you typically are attended at? So this, again, having a copy of this POLST is just really a critical and valuable tool that you want to have in your toolkit packet or in your possession to make this work for your loved ones. The Advanced Healthcare Directive is a very valuable tool as well, but here's the differential between the two. The Advanced Healthcare Directive is a planning document. The POST is an action document. So you'll see that there isn't a medical delivery system that's going to want to sit and kind of peruse through your Advanced Healthcare Directive, which is typically anywhere from 4 to 7 pages, and try to identify what your wishes might be. Rather, they'd like to get right to the point, and that's where the POST can be a much more advantageous form of communication. So I think that's a really valuable tool to have in your toolkit. These are readily available online. They are typically bright pink in color and of cardstock nature, and they are front and back printed typically. So really encourage, and if you have questions about that, we'll definitely address those at the end of the presentation, no problem. The other thing that's a couple other things that are really important would be the current list of medications and any chronic medical conditions that your loved one is facing. This current list of medications is so critical and important. They're going to go through them with you. They're going to want to find out even more so what the current list is, but what did they just recently take and when, so that they are not duplicating or piling on a medication that was perhaps just recently taken. And then a good understanding of the chronic medical conditions that your loved one might be facing, just so they have an understanding. And that you can carry that in a wallet, in a purse, it can be laminated. Meds change a lot. Different doctors are prescribing different meds as it might be. So really critical and important to have that most up-to-date list. We carry, unfortunately have a daughter who has chronic illnesses, and we have a med list and we have the date at the bottom of the med list. So we know that it is the most updated list. So just adding a date so you know that it isn't a year old and that it's been updated is very, very helpful to the medical personnel as they're bringing you into their system and trying to get you taken care of in the course of this visit. Very good to have your insurance information and your identification. They're going to ask you for that. So you want to make sure that that's readily available. Again, copies of that can be carried on phones and can be presented if the rush and the hurry of getting to the emergency room was forgotten. These elements were forgotten. You can always reach back and look at what backup you might have on your person to support the loved one that you're advocating for. Any allergies that are known, medication, food allergies, etc. Really important information to have for the crew that is trying to bring you in and get you taken care of. And if allergies creep up and even any adverse reactions, not even necessarily a technical allergy, but an adverse reaction to any medications or any systems. Again, I'll pick on my poor daughter. She has an allergy to tape that they tape the IV on with. So now her skin just sets a fire. Just letting them know, they're very happy to know that. They'll turn around and go get the tape that is a little bit more expensive, unfortunately, but also doesn't wreak havoc on her skin. Really wise to bring some warm clothing, maybe a blanket, a water bottle. Not necessarily so much for the loved one, but this is now more for you. If you're able to sit bedside and be with them in this journey, you want to be prepared as well. So maybe a quick snack, some reading material, the phone charger, always a good one to bring the phone charger, because unfortunately, while we hope this will be a short transaction, it could carry into hours long. So making sure that you are comfortable and that you're satiated with water, with snacks. Reading material is kind of nice. We always bring, when we go with a client, an iPad so we can maybe look at some pictures, particularly if we have some confusion. It often gives those individuals a change of pace. We might look at some pretty flower arrangements or something that really, a pretty snow scene, because again, it's kind of that hurry up and wait. So this is your chance to just change the channel a little bit as it might be. So, whoops, sorry, there's the polls. So here's the COVID-19 concerns and quandaries. Again, as I mentioned earlier, it's a pretty fluid moment right now, and things are changing at all times. One of the things that we are finding, and this might be helpful, is to communicate to the staff, particularly if your loved one has dementia, has some confusion, cannot articulate answers. You know, guys, I can help you. If you will let me in, I can help answer these questions. I can, pinpoint the concerns and issues. I can keep my loved ones calm, cool, and collected, whereas you might have some difficulty with that. They're pretty challenging. We are finding that this communicating this opportunity and this strength and this relationship may get you in that door more readily as well. And it's quite honest. You are able, to certainly, maybe streamline the situation, keep them from having to perhaps get a sitter to sit with your loved one. Plus, again, you're the historian, you know their details, you know their facts. It will make their job easier in the long run. And I know the hospitals are so desirous of that at this point. You may want to find out you may call in ahead to find out what their current policy might be. Again, don't be surprised if it kind of shifts even from day to day, if not even from shift to shift. So really critical and important that you check in to see what their policy is. Another important one, I think that is very critical. If you are not able to stay with your loved one, then there are some suggestions that we might make. You're going to want to stay in contact by getting the current emergency department physician's name so that you can reach out to that physician when you phone in. You can reach out and ask specifically for Dr. Smith's patient, my daughter, my mother in Bay number 42. By referencing that ED physician's name, you will get faster service and more direct and concrete information. And there can be, depending on the size of the emergency room, there can be numerous emergency room physicians on, etc. So again, getting a name so that you make sure that you connect with the individual who's following your loved one. Get a phone number for the front desk and for the nurses station that your loved one will be assigned to. And they can answer these questions right from the get-go to you. If they're not going to allow you in, then this is the information you need from them so that you can stay in direct contact with them. Don't ever walk away without giving them your information. That'll make it easier for them as well. So we're so in pursuit of what they have, we want to make sure that we give them what we have to offer. You may be surprised. The phone call may be, are you still in the parking lot? Because we're going to need you to come in. We need you to help us out. And you may have a copy of that current med list and their insurance information. This is why our toolkit and or your ability to jot this all down and have it readily available to hand over to the personnel as they walk in if they are going to keep you from being bedside or person side. Many of the times we're finding the emergency rooms are saying, you can go home at this point. Some are suggesting maybe a good idea if you just stay in the parking lot in case we need you so we can monitor the situation. We've had both experiences. We're pretty dogged. We tend to stay in the parking lot and be kind of a nudge if we're not allowed in. Just reminding them that we're here and we're happy to assist them in any way, shape, or form that we can. Again, you can see the importance of a written plan. If it's all in writing, this will be much more conducive and easier for the COVID quandary that we sit in. You want that information to be accurate and you want it to be concise because quite possibly your loved one is not able to communicate that. So a written plan is very, very important and very key to the success that you might experience. So what's going to happen when you arrive? I think, as I mentioned, it's going to be hurry up and wait. The wait times can be insurmountable. I had a client not long ago who ended up with a broken ankle, and top to bottom, we were 9 hours. It was x-rays and it was a scan and then it was a little blood work. And then it was, it looks broken. Man, let's get the orthopedic guy in to see if it needs, does it need anything more than, a cast? Oh, no, it can do with a cast. Oh, now we've got to get the equipment that he can walk out of here with. It just takes some time. We're not their only patient. So we're working through a system. So ways to distract during that wait time, that's where the iPad or some reading material may come in, very help and may be very helpful, but be prepared that this could be a little bit of a journey. As I say of late, they are so conscious of, the social distancing, the indoor concerns, masking, and keeping us apart, that we're finding that the wait times are a little less, but it really, the whole process is triage. You walk in and they immediately are going to look at what the concerns are, and then they are going to order some tests. They have to go about those tests. They have to go about an assessment. They have many different people to look at the assessment to see what they feel the concern and the nature of the illness or the incident might be. Again, there are tests, there are multitudes of lab work that might need to be ordered and done. You may find that they are going in and having those tests done. They come back to the waiting area. They may go in and have tests done, and they may go to an actual holding room, as it might be. Bottom line, that fifth bullet point there, it's a hurry up and wait. And I'm sorry about that. Again, this is your best opportunity to kind of quell the situation, calm your loved one, stay with them, be their advocate, pipe up, speak up, and make sure that that people know you're there and available to answer questions should your loved one not be able to answer those questions. So their goal is to diagnose and hopefully treat. It may entail a number of opinions, a number of viewpoints, a number of tests, and a number of different venues with which to do that testing. But I think ultimately what they're trying to do in the emergency room is do a diagnosis and then subsequently create a treatment plan to address the issue and then determine where we go from there. There may be a determination that admission is the best route. There may be a determination that discharge back home with whatever supportive mechanisms in place that are necessary will be allowed. So we're going to talk about how to get through all of that. There likely will be test results that will come your way. I'm really a stickler about trying to get those test results in print at that moment. So many times they'll say to you, just go in the portal and the patient portal, and you'll see things. But once again, if you're not a patient of this system, and so this is not your portal per se, I would really suggest that you ask for those test results in writing. They're available. Means they have to go to the printer and print them off. But again, this may be very beneficial as you move forward in any follow-up that you need to do with your primary care or with specialists, as it might be. So I just really implore you to get something, if you are walking away, get something in writing in regards to those test results. Very important part of this experience that you're going to have. And they will encourage you, every single ER visit and even subsequent hospital admission, they always encourage you to follow up with your primary care physician within 7 days of an experience, whether you're admitted or not. This really gives your primary care physician the big picture, the whole picture of who you are and what you are. You may find that it was just a silly little fall and they did a couple stitches and I'm good. This is valuable information for your primary care physician. A time to talk things over further, particularly for those of us in an aging world. Sadly, what we may have weathered as a younger person, we don't weather as well as an older person. So again, a fall and a few stitches really opens the door as to, why did we fall? let's talk about that. You know, was it a simple trip? Was it a blood pressure issue? Was it a metabolism issue, glucose issue? There's so much more that can be followed up on and should be followed up on for those as we age. Just, I don't know about you guys, but I'm not 25 anymore, and I just don't rebound the way I used to. So when I go down harder, and it's a lot harder for me to get back up, but right back up to who I used to be. And that's really indicative of anyone who is aging. So it's really important to have that primary care follow-up as instructed by the emergency room. So what happens if you are actually formally admitted? What if you do have to stay in the hospital? And now we've got a very different game plan. So let's talk a little bit about what we're looking at here as far as formal admission, etc. So there actually are two categories at this stage. One is formal admission and one is observation. And they are actually quite different. Even though they're going to lend you to ultimately landing in a room, they are under two very different premise. The formal admission is typically, again, under your Medicare and your supplement addressed in that regard. Observation is not necessarily covered by Medicare and or by your supplement program. So I think it's very, very important that right from the get-go, you get a clarification. Is my loved one being admitted formally, or are they here under observation status only? And observation status just means they're trying to observe and formalize a plan. It may mean that in a matter of hours to days, you will be discharged. It may mean that observation goes into a formal admission because they feel it meets the criteria for insurance, Medicare, and the healthiness of the circumstance. They're not always, the medical system is not always clear on formal admission versus observation. And we find occasionally clients get home and they get a very large bill because they were only under an observation status, and it was ultimately not covered by Medicare and or their medical insurance coverage. So be sharp about that. Again, here we are, if we're not able to advocate for them and we're not there, it would be a very valuable phone call to make once you know that they're admitted. What does that look like? You could make a phone call to the admitting department of a hospital and ask for the accurate status of your loved one in regards to formal admission versus observation. We had a client one time, we were actually sitting bedside, this was well before COVID, and that very, very pleasant, very young, very attentive young lady came in and said, I've just got your paperwork here for your hospital stay, if you'll just sign right here. And we directly asked, is this a admission or observation? And she just kind of looked blank at us and said, she just needs to sign here. Well, our client was not able to speak for herself. So we were stepping in and trying to advocate for her. And really, lo and behold, this was an observation stay. The admitting clerical assistant didn't really quite understand the difference between the two and the value of explaining that to our client. Our client ended up staying 31 days. It turned into a very formal admission, but it was not transparent from the start with that experience. So really important to get a clarification. If it is an observation stay and you feel it should be a formal admission, there's actually an appeal process for that effort. And you would want to speak to the admitting personnel to talk about why does my loved one not meet formal admissions criteria, and get some discussion going regarding those two different categories. When you're admitted, you're now leaving the emergency room and that lovely doctor that helped you through that process, and you're getting a whole new medical team. So it's going to be very important that you get a sense of who's the next doctor that we're going to be dealing with. So typically you're going to be experiencing a hospitalist and or some specialists, as it might be. So you want to find out who that hospitalist is. And I think furthermore, find out what's the duration of their stay. Typically or frequently, they're on a 1 week at a time rotation, maybe a 5-day week, a 7-day week. So they'll follow your loved one. But if the hospital carries on beyond their time frame, or you hit them mid-cycle of their time frame, you're probably going to see another hospitalist. So again, you want to find out who that new medical team is, if there will be specialists called in, and who the hospitalist is. And I would suggest, where are they in their rotation for your loved one? Will they be here through Saturday? Are they released on Monday? Will we be looking at a new face on Monday? So you want to get a sense. You get new nurses every 12 hours, and you get new doctors along the way. So let's make sure that you have a clear understanding of who you're dealing with at this point. And I'll be honest, your emergency department physician saw things one way. It's quite possible that your hospitalist will see things either similarly or in a different venue. So, or from a different view, I should say. So again, you want to make sure that you get through to the next and the new medical team that's assisting your loved one. I think it's really important to get a clarification of what the treatment or the goals and objectives are. And then also a timeline. What does this look like? I don't think that they can dial it down to, yes, your loved one will be in for 2 days and 38 minutes and we'll have this done. But you want some sense of, so if we're going to be on an antibiotic, oh, it's going to be an IV antibiotic. How many days of the antibiotic via IV will we need? Oh, 4 days. Well, now we have a general idea of what the treatment protocol is and what to anticipate. The last thing you want is a phone call the very next day saying, well, you come get your mom, she's good, but I thought she was on a 4-day antibiotic protocol. So again, some sense of the treatment plan that they are attempting to address during this hospitalization. And let me make a comment about our hospitals these days. And I don't want to besmirch our hospitals, but our hospitals at this stage are really an acute care setting. You may come in with all kinds of, additional diagnoses, so as they refer to them, comorbidities, but they really are mostly interested in what brought you in for this stay and this stay exclusively. And that's what they're going to go about treating. So if you came in for a broken hip, but gosh, your shoulder's been bothering you and your diabetes is out of control, they're wildly interested in that shoulder and that diabetes status, but really they're going to treat what you came in for, the diagnosis they came up with. They're going to treat that and they're going to discharge you as quickly as they possibly can. They may discharge you to home, they may discharge you on to further services. So again, all the more reason to get a clarification of the treatment and the treatment plan. And as you can, you might want to pipe up a little bit about those other elements that your loved one faces day in and day out. And we go through this with my own family, with my daughter. We tend to come in for one presentation of her chronic illness, but we try to continually remind them of all those other chronic issues that she faces and how they play into the current presentation that brings us to the hospital for that particular circumstance. You then have ongoing advocacy and as much communication as you can possibly get. Just continuing to be present and be available and to check in with staff ongoing is really important. I'm a firm believer that you catch more bees with honey. So we don't have to be ugly about anything, but just that consistent, just want to know what's going on with my loved one today. Can you give me an update? It's sometimes hard to nail down doctors exactly as to when their visits and their rounds might be. But sometimes you can get a good sense. So start asking, and then important to make sure that the protocol and the treatment plan appears to be successful. Will it be morphing? Will it be changing? And if so, what adjustments, what adaptations are they making, etc. And making sure, again, you left your contact information with the ER or the emergency department, you want to make sure that that contact information now is available to the current staff and the current individuals who are providing care. Most of our hospitals have those lovely whiteboards that are available. You can put your name and put your number up there. Really helpful, really important. But what if you can't get in to put your name and number? Again, if you have something in writing that may be attached to that whiteboard, then people will know, etc., how they will contact you. So the more we can communicate, the better we'll do with this experience. Really critical. So here's the tough one when we have that added layer of dementia. This is when we are even a more invaluable advocator for our loved ones. Our loved ones are not able to adapt to the clinical setting. We have to ask the clinical setting to adapt to them. And so we want to make sure that we let the staff know what those limitations might be, cognitively, etc., so that you can be present to help make this transaction go smoothly. You want to be helpful in regards to controlling the environment, supporting the environment. Perhaps your loved one doesn't do well with a bevy of individuals coming in and going out constantly. Their confusion ratchets up as a result of that. So again, if we can remind them that your mom, has difficulties in the afternoons. Her mornings are her difficult time. She wants to get up and go. By the afternoon, she's kind of tired and worn down. Whomever your loved one is, the more that you can share that information, inform the staff of who she is or who he is and how they best do, how they're best approached. This is going to be very, very helpful and make everybody's visit a whole lot easier and a whole lot better. We had a client one time who was really not cognitively challenged, but she was literally legally blind. And she spent days in the hospital, day in and day out. And one of the simple criteria that she asked, because she was legally blind, she simply asked that anybody who came into her room just address her and tell her, hi, and she liked to be addressed formally. She did not like to be called Sweetie or Susie or Suzanne. She liked to be called by her formal name, Mrs. Smith. She also liked you to walk in saying, hi, Mrs. Smith, this is Gail, and I'm here to take your blood pressure. She would be putty in your hands, but for you, and she would acquiesce and allow you to do those protocols that you need to get done. When you didn't acknowledge and announce yourself, she was immediately on edge. She could hear your presence. She could smell your presence. But she would often say, who are you? And no, you can't do my blood pressure. We posted a sign outside her door that said, please announce yourself when you come in this room. Please address room 112B by her formal name, and please let her know what you are hoping to do for her at that moment. Again, very simple. By putting a sign right outside the door, it just made it easy, and everybody was successful at that point. So that's how we can control the environment a little bit more and get that engagement with that loved one as it might be. And then bottom line, ask for help. What are your suggestions to make this stay a little easier? What can staff do? How can you help me? What do you need? I can help you if you can help me. I think if we just communicate with one another, we'll get through this experience a lot easier. I can't tell you the number of times recently that we've had clients who've gone to the emergency room and they have caregivers with them. And, the first immediate is, stop, don't come in, you can't come in. And our caregivers would say, but I'm the caregiver and I can keep her calm and happy. And this is before we've arrived. And we get to the emergency room and we too are stymied. And but we've got the caregiver waiting out in their car. And I can't tell you the number of phone calls within an hour or two that I've gotten where the hospital has said, hey, is that caregiver around? Because we sure could use her. Could she come in and sit with her? Because we've all been hit 5 times and we'd really like to get a blood draw, but we are not making any progress. And so we were happy to get that caregiver in there. They asked for help, we gave it, we offered help. But if you have questions or concerns, ask for some guidance. There's all kinds of levels to get to in regards to trying to get some of that help and get that partnership, so we can make this as quick a journey as possible and get people back to their homes, as it might be, whatever their home may be. So you've gone through the experience of being admitted, and we've gotten through all the bags of fluid and the bags of antibiotics, and we've gotten the wound looked at, or we've gotten the stitches in place, etc. But now it's time to go home from the emergency room or from the hospital. Really important. Again, I can't implore you enough to ask them to please print out any test results, from blood work to scan transcripts, etc. Whatever they have, they should be able to give to you. That's not a HIPAA violation. That's the right of the individual, and that information will be helpful for your primary care physician. It's also helpful when you get home. It all becomes a big blur and you're just exhausted and tired, and that opportunity to go back to the paperwork and revisit what you experienced will be very, very important. Get your follow-up care in place. And this might mean, will there be a home health person coming out to follow you, to check on the incision or to check on an injury or a wound or sutures, as it might be? Will there be physical therapy to follow you? Whatever the follow-up care might be, it will be critical and important. I know as a personal experience, I'm sorry to keep picking on personal, but maybe it'll resonate. Every time my daughter is admitted to the hospital, she has home health that follows her. Home health is immediately cut off the minute she's admitted to the hospital, because you can't have dual representation there, dual needs. So every time that she's discharged, we have to say, oh, by the way, we need home health, and it just restarts again. We've been very fortunate in that regard. So you just want to make sure that you get follow-up care in place. If there's durable medical equipment, such as a walker, a wheelchair, a bedside commode, etc., making sure that there are orders for that, or that there are instructions on either that equipment coming with you or how to get your hands on that equipment. For some of our residents, our clients, they go back to residential care settings. Everything that is ordered in a hospital, an emergency room visit, must have a signed order. You can't just say, oh, yeah, and if your mom gets a headache, tell the facility to give her a couple of aspirin. Doesn't work like that. We need written, signed medication orders for anything that comes back into a facility. And so the last thing you want to be is tracking down signed orders for things that your loved one needs in the residential care setting. So I encourage you to get that right at the discharge moment there. I had an experience with a Kaiser physician where, again, it was sutures that were necessary for my client. And I said, she's in a facility, she'll need Tylenol. Can we get orders? Oh yeah, you just go down to the pharmacy, you buy Tylenol. So now I know where to get the Tylenol, but she can't keep it in her room, and it goes to the medication tech's room, and they'll need an order. Oh, no. Yeah, you just go to the pharmacy. They'll give you some Tylenol, not a problem. Clearly, I wasn't articulating well. Finally got through to that doctor and said, no, I know where to get it, but here's what we're up against. And finally, we were on the same page with that. Sometimes you'll have new prescriptions. You'll need a pharmacy consult. You don't get prescriptions at the emergency room, and you don't get prescriptions upon discharge. They send orders for that. So you want to make sure if there are new medications and there are things to pick up, you want to make sure that you get that insight and get that information. And of course, these new meds now need to be listed on the medication list that you've drawn up and updated. Even if they're temporary, it's very important to put them on that new medication list, or on that medication list as a new med. You can note that it started on this day and it finished on that day, but it will be very, very helpful to make sure that that information is formally in the system as it might be. And then ultimately, there may be a need for some help at home, and this may be home health, it may be companion care. So you want to get a sense of what assistance might be available upon discharge from either the emergency room and then subsequently if there's an admission to the hospital as well. There are two forms of help at home, as it might be. One is home health, and that is from the doctor's order, and it's attending to periodically to the issue that brought you to the hospital and the treatment that was attended to you while you were at the hospital. There is also then companion care support, and you may have to reach out and find some companion care for the fear and the concern that your loved one would not be successful at home alone. The home health assistance is covered through Medicare. The companion care is all private pay. So even though the hospital may say to you, oh yeah, we'll send a nurse out. Well, they're not going to send a nurse out to sit with you bedside 24 hours round the clock. They're going to send a nurse out within the first 72 hours of arriving home. And that individual will land at your doorstep, assess the situation, see if there's further needs for that should be attended to, and take a look at the concern, and then they're gone. And they may do that for a couple of visits for up to a couple of weeks, but ultimately that will disappear, and you may need that companion support at home to get through this hurdle from this most recent visit to the emergency room. If you're coming home from the hospital, you'll actually be working with a discharge planner. So this is someone outside of the medical team per se, that, believe it or not, the minute you're admitted, they're alerted that there will be a discharge coming. I always find that so rather interesting that, you know, the minute you arrive, you're actually on the radar of the doctors, of the nurses, and of the discharge planner, because they are working toward a successful discharge on your loved one's part. So you're very welcome to ask at some point to speak with the discharge planner so you can get a sense of the timing. Now, again, they won't be able to tell you right that minute, yep, we think this will happen in 72 hours and 47 minutes, but they will be able to work with you on concerns for when that discharge comes. And this is a great opportunity for you to be able to say to them, gosh, mom's been alone at home. And no, we have stairs to get up. And oh no, her bedroom's upstairs and you know the bathroom is downstairs. These are elements that you and the discharge planner can talk about in preparation to make sure that the accommodations that are necessary to make that stay at home much more successful as it might be. There are durable medical equipment items that the hospital and Medicare may be able to line up to have delivered to your home. And they include, as I mentioned earlier, a walker, a wheelchair, a hospital bed, a bedside commode. All of these things you may be eligible to have delivered to the home or to the residence where your loved one is residing. But they are not all a given. There will have to be criteria that the discharge planner and the doctors will have to articulate to show that you are in need of these items. And then those items will be available to you for whatever period of time that you might need them to be in your home or in the residence of your loved one. There are also durable medical equipment stores that may provide you with these items at a cost if they are not approved by Medicare. And I'm always under the premise of if you don't ask, you don't get. So I tend to ask for everything under the sun, and then I bargain with what I'm able to negotiate and grab for my loved one. And even if we're not going to need it forever, or we're even questioning, maybe we won't need that, I encourage people to grab the DME equipment. You can always store it away if you aren't using it right at that moment. That's really an important element. Rehabilitation. As I mentioned earlier, the hospital stay is really about that acute issue that is presenting itself. Very little, if any, rehabilitation goes on in the hospital. That is reserved either for a temporary stay in a skilled nursing facility if you meet criteria, or it's geared at going home and bringing those rehabilitative services to the home or residence, whatever it might be, residential care setting. So the rehabilitation, if you are not in a managed care environment, i.e. a Kaiser, you need to have 3 consecutive nights in the hospital as a full admission, not an observation stay, to qualify potentially for a rehabilitative stay in a skilled nursing facility. So if you opt to go that route, you'll go to a skilled nursing facility and you will receive physical therapy, occupational therapy, speech therapy, and potentially wound issues if that's an element of what your hospitalization was all about. This is typically a short-term stay, and it is all geared at your rehabilitative efforts. This is where you get that language that says you have up to 100 days in a skilled nursing facility. And the key words there are not 100 days, they are the words up to, because our average skilled nursing facility stay geared at a rehabilitative component is essentially about 12.9 to 14.3 days. So it typically is a very short-term experience where you are really getting that maximized effort to get you back to as close to who you were prior to the incident that brought you to them. And it may not happen in that short time frame, but you're working toward that rehabilitative goal of back to who you were prior. So again, that rehabilitation stay, you're going to work with a discharge planner to see if you qualify for it, if you want it, and then where you would go from there. It is the discharge planner's responsibility to try to help you find a rehabilitative stay that's conducive to your insurance and conducive to your family dynamics. You may have some home health if you decide, again, perhaps maybe to bypass or aren't really in need of a rehabilitative stay in skilled nursing. You then would head home and you would have those same services, physical therapy, occupational therapy, speech therapy, and or wound or incision care as you might have need for in the home, carried on by a home health system. This again is going to be short-lived. It will not last for long. I'm a big proponent of, even when they tell you that it's coming to a close, you always ask for a few more sessions, particularly with physical therapy, occupational therapy, etc. Couldn't we just see if maybe we can get 2 or 3 more sessions so that all of those services are coming as often as possible and to the maximum that they can be dipped into. Again, don't ask, you don't get. These can be done at home, and they can be done also, these services done in a residential care facility. All of that covered under the Medicare component or insurance component for whatever coverage you might have. And then there's supplemental care, and this is more that home companion type care. This is where the doc so casually says your mom should have 24-hour round-the-clock care. She should never be alone. What does that really mean? That doesn't mean that she needs someone sitting bedside taking her blood pressure every 5 minutes, but can she navigate and get to the kitchen? Is dad strong enough to get dressed each day and get out to the, his favorite chair or get to the bathroom or get to the kitchen to get some meal assistance, as it might be. So supplemental care you can bring into the home. The rub of some supplemental care is that this is a private pay entity, and that's how you're going to cover it, is out of the pocket of your loved one. Many of our supplemental environments or supplemental services can be a minimum of 3 and 4 hours a day. They can go to a maximum of 24 hours a day. So the nice part about those services are they can kind of start and stop on a dime, and you can contour them to fit your particular circumstance. Sometimes it's beneficial to start with 24/7, and then as we see the strength regaining and the abilities coming back in play, you may be able to reduce those hours down to 12 hours a day, and then down to 8 hours a day, and then maybe down to 4 hours every other day, as it might be, as you watch your loved one gain strength and get back to who they were. So there's a lot of options here. You just have to know what these all are and how to go about asking for them and what they look like as you go through this experience. So who pays for what in all of this? You know, you have your insurance coverage, your Medicare, if that's your provider, or your private insurance and your supplements, et cetera. You will have co-pays, et cetera. Again, as we mentioned, the criteria for rehab, for those of you who are on Medicare, those of you who have loved ones on Medicare, it is a minimum 3 consecutive nights in the hospital. That's what qualifies you for that rehabilitative stay. Remember, that's where you get up to 100 days to go through that rehabilitation effort, but very rarely do we see anybody spend 100 days in that rehabilitative component. We typically see a much shorter stay for them. If you don't feel like the discharge is safe, you don't feel like the discharge is either from the hospital or from a skilled nursing facility, you absolutely have the right to appeal that discharge. There are processes that you must go through. We're very happy to walk you through that. We didn't want to take time today because that's a very individualized experience, but there is a legal and appeal process that and the hospitals have to assist you with that. The skilled nursing facilities have to assist you with that, as does Medicare. The challenge in appealing a discharge is if you do not win that discharge and you stay beyond the qualifying period that has been approved by your Medicare and or insurance company, you may end up with a pretty large bill because they may find that you are the one that you didn't meet criteria and therefore you're the one that has to pay that bill, as it might be. We always encourage you to have Plan B in your back pocket. And so understanding, again, the pathing of all of these different choices is really important. And I'll share again a personal note for you. I remember many years ago when my mother unfortunately fell and broke a hip. We also, more unfortunately, she was in the throes of lung cancer, very ill. And they were able to repair the hip. She did really well with that. And they called us and said, okay, so now your mom can go to a skilled nursing facility and this is great. Well, we had a plan B. That was a very nice offer, but we knew mom's life was very short. Unfortunately, she wasn't going to win this battle. And so we looked at the discharge plan at the hospital and said, no, she's going to come home. We'd like her to come home. Well, they needed us to articulate how safe is home. Can she get in that home? Can she get out of that home? God forbid there be a fire or concern. We actually had to articulate to them and verify with them that her home was safe. It was one story. We had a caregiving team in place and she could go home. But I really encourage you to have a plan B in your mind. You know, if someone doesn't want to go to skilled nursing, someone can't go to skilled nursing, if someone doesn't qualify for skilled nursing, you should always have a plan B in mind. And I'll be honest with you, creating plan B when you're in the middle of the crisis isn't always best. So talking through these scenarios, looking at assets, talking about what these things cost, talking with your loved one to see what their wishes might be. I remember, clearly saying to mom, you're going to come home. Oh, is that what the doctor suggested? And I said, no, actually, mom, the doctor suggested you go to a skilled nursing facility for some rehab, but we thought you might want to do that at home. I do. I want to get home. Mom was very cognizant. She knew she was very ill. And the last thing she wanted to do was spend 2 weeks of her last months on this planet in a skilled nursing facility trying to fight her way back. As it was, she fought her way back and she lasted 5 more months, which we were delighted with. It wasn't the hip that took her. It was unfortunately cancer that did. So again, we had plan B and we as siblings had talked about, dad was already gone. What would we do? And but we had that plan in place. We were prepared and ready. And I think one of the things when you think about plans, we knew we had a short lifespan here. It was easy. You can do anything for 5 or 6 months. When we're looking at long-term chronic debilitating diseases, dementias and Parkinson's, it's a long road. So you want to make sure that your plan B has legs and that it's been thought through. And then that's why all the more reason not to be trying to develop that plan B when you're right in the middle of the crisis. We make so many better choices when we've planned ahead and we aren't having to address that crisis as it might be. So we're a real big one on planning. Just because you plan doesn't mean that the incidents or the occurrences are going to happen. Just means you're ready. Just means you've done your due diligence, you've done your homework, and you're ready to tackle whatever you might have to face. We don't have a crystal ball. We don't know what what your future might bring, but we can certainly talk with you about intelligent planning for the future as it might be. We're huge advocates for that. But I'll be honest with you, we do most of our business in the crisis mode, and that we're happy and delighted to be able to help anyone at any time, at any stage in their journey in this aging process. So that's our 911 on how to deal with 911 and the emergency visits as it might be. You can see that this is some information about us and who we are and how we work. And